Okay, so why did I choose this particular subject? Because gastroenterology and hepatology has a lot of interesting topics, but I think this is a bit of a neglected topic, and so that's why I choose this. So this is one of the most prevalent infections in the worldwide, if not the most prevalent one. It is estimated that more than half of the world population is infected with H. pylori infection, and this is top carcinogen, and this was classified as a top carcinogen by WHO since 1994. If I am correct, I think this was the first bacterial pathogen which is classified as a carcinogen, and this was first described in 1983 in association with chronic gastritis, and this is transmitted from human to human, and it has been assumed that this bug was living with us for a long period of time, and eventually it has evolved with humans as well. So this causes chronic active gastritis in all colonized subjects, and this is associated with several gastropathies. Chronic gastritis, peptic ulcer disease, both gastric ulcers and duodenal ulcers, and also mucosa-associated lymphoid tissue lymphoma and gastric cancer. And H. pylori eradication cures gastritis and can alter the progression to long-term complications or recurrence of disease. So it is very important to diagnose this condition and start proper treatment in order to prevent these possible clinical sequences. So this is a meta-analysis done by Ford et al. And this is regarding ulcer recurrence rate according to treatment for H. pylori infection. So in here, they have used about 35 trials. In this meta-analysis, they have analyzed the data on patient who had peptic ulcer disease with active H. pylori infection. And then there were two groups. One group was treated for H. pylori, and the other was the placebo or the control arm. And after analyzing, it has been shown that eradication of H. pylori was associated with significantly lower number of ulcer recurrence, both in duodenal ulcers and gastric ulcers. And also you can see that number needed to treat is so low, which is good, because if you treat you just need to treat 2 patients to prevent duodenal ulcer recurrence, and you have to treat just 3 patients to prevent the occurrence of 1 gastric ulcer. And this meta-analysis showed the association between H. pylori and gastric cancer, again by Ford et al. I think he is one of the world frontier on H. pylori infection, who's in US. And in this meta-analysis, they have analyzed the data from 7 RCTs from Asia, so which is very similar conditions to our country. So in this, they have identified 8,000 plus healthy people with active H. pylori infection, and then they have randomized them to active treatment versus placebo. And this meta-analysis has shown the treatment of infection has led to reduced incidence of gastric cancer and reduced mortality from gastric cancer. And again, this is another study which again showed the association between H. pylori and gastric cancer. Again, with that, they have shown that successful confirmed eradication associated with 76% reduction in gastric cancer. So not only the GI tract, but there are some extraintestinal associations as well. So some well-proven association is iron deficiency with or without anemia, and also adult ITP. Actually, there are several other disease conditions that they have proposed that there may be association, but those are not proven. Those are stroke, Alzheimer's, and some HSP, Henderson purpura, to name such. But These two conditions are, they have proven that there may be a significant association with H. pylori infection. So this study done by Stacy et al. So they have identified 696 adult patients with ITP and who had active H. pylori infection. They have treated for ITP. With the treatment, 43% had complete response, defined by the platelet count has risen more than 100,000, and 50% had partial response, defined as more than 30,000 or doubling from the baseline count. Therefore, the American Society of Hematology recommends screening for H. pylori in all adult ITP patients, and if it is positive, we should eradicate. But I think this recommendation we can incorporate into our daily practice as well. So a few words about epidemiology. It is assumed that 70 to 90% of people in developing countries are infected with this bacterium, and whereas in the developed countries, the prevalence is much more low. In USA, it is around 35%. In our country, there are very few studies on H. pylori prevalence, and unfortunately, the prevalence varies widely. According to one study, the prevalence is 9.7%. In other study, it was 70%. This could be due to the different diagnostic methods they have used, and also the biopsy protocol and the previous use of antibiotics. And I think these reasons might have affected this wide variability in the prevalence. But unfortunately, we don't have any firm data regarding our country's prevalence. So this is a map of the world prevalence, and you can see that Pakistan, Russia, and Brazil, and those countries have a very high prevalence. Also, our neighboring India, they have also a relatively high prevalence, but in our country, we don't have data. So prevalence of so looking at that map, it is obvious that prevalence of H. pylori is reflected by the degree of the socioeconomic development, and basic resources such as access to clean water, healthcare, modern sanitization plays an important role in H. pylori prevalence. And this is transmitted from person to person or via a common infected source such as a water supply. And transmission is thought to occur through gastro-oral, oral-oral, or fecal-oral route. So this gastro-oral means they have isolated H. pylori in gastric vomiters. So that's why they have proposed this gastro-oral route as well. But we don't know the predominant mode of transmission. So a few words about pathogenesis. And this is a gram-negative spiral flagellated bacterium. And this bacterium uses its flagella to move towards the gastric epithelium and also to penetrate the mucous lining. And this bacterium lives near the surface of the human gastric mucosa. And they have evolved a lot of mechanisms to avoid the bactericidal acid in the gastric lumen. And especially worth mentioning that they have an enzyme called urease. They use that urease enzyme to metabolize urea into ammonium and carbon dioxide. This carbon dioxide in turn reacts with water and produce bicarb. So it makes a little bit a basic environment for the bacterium. And this is a cartoon representation regarding the virulent and colonization factor. So it has urease. This is the flagella, and it has a lot of adhesions molecule to attach to the gastric epithelium. And this VAC-K and CAG-A are some virulent factors. I'm not going to go into details. And this is this is a bit of a crowded slide. You can forget about this. And so, as I mentioned earlier, this is usually acquired in childhood. And chronic gastritis will develop in virtually in all patients, but only 80 to 90% of patients, 80 to 90% of patients will never have symptoms. And the clinical cause is highly variable and depends on bacterial and host factors. And this bacterium infection with this bacterium can cause high gastric output in some patients. In some patients, it will they will have low gastric output, and some will have normal gastric output, gastric acid output. So the patients with lower acid output are more likely to have gastritis in the body. In the body of the stomach, and this group of people are more prone to develop gastric ulcers. In very rare cases, it can initiate a sequence of events leading to gastric carcinoma. And also in this group, they can develop this mucus-associated lymphoid tissue lymphoma, and rarely again this can lead to malignant lymphoma. So this is again the three different phenotypes of H. pylori infection. So the most of the patients will have this simple gastritic phenotype without much of a significant clinical outcome. And this patients with antral predominant gastritis, they are at risk of developing duodenal ulcer phenotype, and they will have high gastrin and acid secretion. And this about 1% of the infected subjects will develop this gastric cancer phenotype, and they will have corpus, that is body predominant gastritis, and there will be multifocal atrophic gastritis. They will have high gastrin output and hypochlorhydria. And these are some host bacterial and environmental factors which can ultimately decide the clinical phenotype. And you can note that, of course, there are some modifiable risk factors as well. So the smoking and diet, which we can modify. So again, the same thing in a different manner. So as I mentioned earlier, you can see that this infection can lead to high level of acid production as well as low level of acid production or normal level of acid production. So then we will move on to investigation. So the current recommendation is a test and treat approach. So it is not so if someone is having dyspepsia, always we should investigate. We should not empirically treat with H. pylori. So so there are two sets of investigations I will describe in my latest slide. So in young patients with uninvestigated dyspepsia, test and treat strategy with non-invasive test is preferred. And when there is alarm symptoms, we should go for invasive or endoscopic investigations. So this is a bit of a crowded slide, but this is a very good flow chart. I'll try to explain this to you. So young patients, so the young is defined as less than 60 years of age. So almost all of us are young, so it's good. And patients, young patients with uninvestigated dyspepsia without alarming symptoms. The alarming symptoms would be dysphagia, loss of weight, upper GI bleeding, that is hematemesis or melena, or coffee ground vomiting, and weight loss. We can go for non-invasive screening. I will describe what are those. And if we are planning to start a chronic NSAIDs therapy in someone, again, they recommend to evaluate for H. pylori. And some ethnic groups, such as Asians, Hispanics, and Afro-Caribbeans with dyspeptic symptoms. And as I mentioned earlier, adults with ITP, again, we should go for non-invasive testing for H. pylori. And this is a bit doubtful. This is they recommend people who are on chronic use of low dose aspirin. Again, they suggest, some colleges suggest that we should check for H. pylori using non-endoscopic investigations. We should go for invasive or endoscopic investigations. Patients who are age more than 60 with uninvestigated dyspepsia, irrespective of presence or absence of alarm symptoms, or irrespective of the age, if someone is having alarm symptoms I described earlier, we should go for endoscopic evaluation. And if someone is having active peptic ulcer disease or previous history of peptic ulcer disease, low-grade mold lymphoma, or previous history of endoscopic resection of early gastric cancer, we should go for endoscopic evaluation. And also gastrointestinal metaplasia, we should go for invasive screening. If we yield a positive result from either of these results, we should go for treatment, and then after some time we should evaluate the patient for, or the screen the patient for eradication. If it is if there is eradication confirmed, if the patient is having high risk uh, 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 is in high risk for malignancy, then again we should go for long-term endoscopic surveillance. If not, we can stop the surveillance. I will explain how we can examine for or the screen for eradication in my latest slides. So now a few words about our non-endoscopic investigations and endoscopic investigations. So one of the commonest used investigation is urea breath test, but unfortunately in our country we don't have this. So this is some cartoon presentation of what we do in urea breath test. Again, we use the principle that the H. pylori has that urease enzyme. To remind you all again, mammalian cells don't contain urease. So in this test, we use radio-labeled urea, either C13 or carbon 14. C13 is preferred because it is not radioactive. So we ask the patient to drink or ingest this radio-labeled carbon-containing urea. If the H. pylori is present, this will be metabolized into ammonium and carbon dioxide. Carbon dioxide will then later become then this carbon dioxide is absorbed into the bloodstream, and then later it will be exhaled with our breath. So we can measure the amount of radio-labeled carbon dioxide in breath, and if this is positive, we take this as a positive UBT. And although this is not available, this stool antigen test is but again only in the private sector. Previously it cost around 2,000 rupees, but actually with this current crisis, I don't know what is the cost for this. And again, the serology we can use, but serology is mainly for not for in clinical practice, but for research purposes, because we can measure IgM, IgG, but we can't differentiate between the past infection from the acute infection, although we can assess IgM. So it is not very recommended in the clinical practice. And I have seen in some private hospitals, they offer this gastritis packages. In those, they use the serology, but in clinical sense, it is not, there's no use. So what are the endoscopic investigation? Again, we can use this rapid urease test, in which we take biopsies, and then it is a bedside test which can be done at the endoscopy suite itself, and this is known as a flow test. Again, it uses that the presence of urease in the H. pylori. If the urease is present, again there will be urea in that slide. So it will make ammonium, and the production of ammonium will be indicate as a color change. And also we can take biopsies for histology. So most of the time we can take routine staining using H&E, and at times we can go for histochemical analysis as well. So also we can use a PCR, again PCR for the research purposes, not mainly for clinical context. And also we can take culture and ABST, and this is being a microaerophilic bacterium. I think it needs special culture media and special transport media, so the culture is not that easy. I think Dr. Chamta might speak few words about that after my presentation. And so one important thing, before doing a urea breath test or the stool antigen or the claw test, that is, we should stop antibiotic and bismuth containing compounds at least 4 weeks before the testing, and PPIs at least 2 weeks before. And sometimes some papers ask to stop the histamine receptor antagonist as well, but some papers they say that we can continue the ranitidine or famotidine. Actually, it it is better if we can stop antibiotic and bismuth containing compounds and PPI even before biopsies as well. So what are the tests we can use for to assess the eradication? So again, we can use the stool antigen and the urea breath test. In our country, we can we can easily use this stool antigen if the patient can afford. And there's no place for serology because, as I mentioned, we can't identify the acute infection from the previous infection. And again, we should test for eradication after. So we are using antibiotics and PPI. So at least there should be, we should stop the treatment 4 weeks. After finishing the treatment, we should wait at least for 4 to 6 weeks before testing for eradication. So I think we have discussed this already. So the treatment. So there are first line therapies and also salvage therapies. So before selecting on a regime, there are a few things we should consider. We should ask about patients' recent history of macrolide and quinolone exposure. Actually, I mentioned that this infection was acquired in the childhood and this bug is living in the stomach. So basically, this bug has exposed to all the antibiotics from the childhood that we have ingested. So at least we should ask about the recent exposure to macrolide and quinolone antibiotics. And then since most of these regime contain amoxicillin, we should ask and the type of the penicillin allergy. And also one important area is resistant to clarithromycin and the levofloxacin in the our geographical area. But unfortunately, again, because of this difficult culture procedures in our country, I couldn't find any data on clarithromycin and levofloxacin resistant rates. And the treatment regimes must always contain a proton pump inhibitor and a combination of 2 to 3 antibiotics for 10 to 14 days. And we have to incorporate proton pump inhibitor because of a very particular characteristic of this bug. Because when the pH is low, H. pylori is in a coccoid form, and the antibiotics cannot work properly on the H. pylori when it is in this coccoid form. But in high pHs, that is pH around 6 to 7, it again goes into that helical form, or the spiral form. In that form, it is more susceptible for the antibiotics. So that is why we are incorporating PPI in most of these regimes. So these are some first line therapies. So we can use clarithromycin triple therapy. I think this is the one we are most familiar with. And also bismuth quadruple therapy. Again, bismuth is not available in our country. We can't use this. Good alternative is this concomitant therapy. And there are some other treatment options: sequential therapy, hybrid therapy, levoflox triple therapy, and fluoroquinolone sequential therapy. I will describe those briefly. So this clarithromycin triple therapy, it contains a PPI, clarithromycin, and amoxicillin. If the patient is allergic to penicillin, we can use metronidazole, and the treatment should last for 14 days. I think our practice was just to treat for 1 week, and some commercially available combined treatment contain only 1 week of medicine. So if you are going to prescribe, please prescribe 2 packs. right? That widely available commercial pack contains amoxicillin, uh, clarithromycin, tinidazole, and lansoprazole. I'm not going to mention that name. So the success of the clarithromycin triple therapy depends on the rate of clarithromycin resistance. And if it is resistance rates exceed 15%, it is better to avoid clarithromycin triple therapy. And the guidelines are, if we don't know the clarithromycin resistance rates in a particular country or area, better to avoid treatment. So in our setup, I think it is better to avoid clarithromycin triple therapy. So again, since we don't have this much, we can't use this regime. So what we can use is this concomitant therapy, in which we can use a PPI, amoxicillin, clarithromycin, or a nitrimidazole, metronidazole, or tinidazole. So we can give this to 3 to 10 days, but in our setting, it is better to give at least 10 to 14 days. And this has a very good cure rates around 90%. So this is a very good, this is a good regime we can adapt to our country. So a few words about this sequential therapy. So in this sequential therapy, initially for 5 days, we treat with PPI and amoxicillin, followed by another 5 days of PPI, clarithromycin with metronidazole. So this overall success rate is around 84%, less than concomitant treatment, but this is more successful than the clarithromycin triple therapy. Hybrid therapy. So this is initially we treat the patient with 1 week of PPI and amoxicillin, followed by another 1 week of PPI, amoxicillin, clarithromycin, and metronidazole. The efficacy, tolerability, adherence did not differ from that of sequential or concomitant treatment. And this is an alternative to, again, another alternative to clarithromycin triple therapy, but for patients, I think this is a bit more complex for our patient, I think. So also we can use levofloxacin in several regimes. We can use those as triple therapy, modified sequential therapy, or quadruple therapy. But again, in our country, we don't have levofloxacin resistance rate. I wonder, looking at our prescription, maybe our people may be having more levofloxacin resistance than Clarithromycin, I think. So, treatment failure. So, treatment failure is defined as unsuccessful eradication of H. pylori indicated by non-serological based testing. So, in our setup, it is that we have to repeat after 6 weeks. The H. pylori is stool antigen. If it is positive, it is we can classify it as a treatment failure. In UK, the failure is around 20 to 30%, but in some countries it is high as 50 to 75%. This is due to rapidly rising antibiotic resistance. So in these cases, we can use this salvage therapies. There are several flow charts or algorithms we can follow. So the basic things to consider is we should avoid using the same antibiotics. And again, the selection should be based on local antimicrobial resistance and also the recent exposure to antibiotics. So these are some options we can use. We can use levofloxacin triple regime for 14 days if we haven't used levoflox in our earlier regime, or if we haven't used the concomitant treatment as the first line, we can try concomitant therapy. And also this rifabutin containing triple regimes. Again, I don't think we have this antibiotic in our country. I'm not sure about that. And we should never use clarithromycin triple therapy as a salvage treatment. And there are few new treatments. I would like to discuss about only one drug. This is vonoprazan. This is an oral anti-secretory drug. It is a more potent and long-acting acid suppression than traditional PPIs, that is omeprazole, esomeprazole, pantoprazole, or lansoprazole. So this improves antibiotic efficacy and it competes with potassium reversibly to block hydrogen potassium ATPase, and this is more acid stable and less impaired by this liver enzymes, and potency is more than 350 times that of traditional PPI. So this is a good drug, acid suppression drug that might be available in the market in few years' time. So these are my references, and thank you very much. I would like to answer any questions if you have any questions. Yeah, actually, they do, but I take biopsies only if there is at least erosions. Actually, it is routine, strong practice. If it is the patient is having dyspepsia, we should, in a high prevalent country, actually we need to do biopsies, but unfortunately, I don't want to burn the already overloaded pathology lab. That's the thing. But if there is ulcers or at least erosions, I do take biopsies. But when taking biopsies also, there are several things. So when taking biopsies, we should avoid ulcerated areas. We should take biopsies from the nearby areas. To look for dysplasia, metaplasia, or malignancies, we should take biopsies from the ulcer edge. But if you want to examine for H. pylori, you should avoid those areas. And if the patient is on PPIs, we should take biopsies from the gastric body or the fundus, because when there's low acid, so when we give PPIs, the acid production is low. Then the H. pylori tends to migrate to the more proximal areas from the antrum. We should not take biopsies from the antrum if we want to take in a patient with the PPIs. If we have stopped PPIs, we should take biopsies from antrum, 2 from the antrum, 2 from the gastric body, both from the greater curvature and the lesser curvature, and 1 from the incisura. That is the modified Sydney protocol. So at least we should take 5 biopsies. For flow test or the staphylococcus test, we should take 2 biopsies, 1 from the antrum, 1 from the gastric body. At the moment, from time to time, they have, especially in the MRI, we can get down, but in the private sector, they have, it's again cost around 1,000 rupees per 1 slide. And we can get the results, most of the commercially prepared one, we can get results within 1 hour. In some preparation, we have to observe for 24 hours. In that case, we'll have to send the slide with the patient home and ask them to WhatsApp the picture after 24 hours. So, yeah. So I am also to be blamed sometimes when I see some erosions. I also blindly prescribe the H. pylori eradication, but that is not the case. And actually we have seen that even patients presenting with dyspepsia, sometimes some people tend to use H. pylori eradication, which is wrong practice. And Dr. Chandra, would you like to add something?
I think the main problem is the deficiency in our laboratory diagnostic part. So, for the increased use of antibiotics and all, actually,
Actually, when it comes to laboratory diagnosis of H. pylori, I think it is a main section that should be improved, and it is to be improved in our laboratory settings. Actually, this involves this H. pylori culture needs expensive selective media like culture calls spirose medium. So basically it is not available in the this MRI, which should be available actually. The reference lab should have those medium, but at the moment we are not having those mediums at MRI at all. So what is available at MRI at the moment is I think the serology. They are doing IgM and IgG levels in serology lab, and stool antigen was available some time ago, but it is not available at the moment. So we have to, as you said, there's no clinical value of serology at the moment. So we have to improve our culture facilities so that we can get the isolates and do the antibiotic susceptibility testing to know the sensitivity pattern of our strains. So as Eranga said, that antibiotic resistance is a major problem. So as is H. pylori, when we acquire it, it is there from the childhood, from the beginning, and now with the amount of antibiotics that we are exposed from the childhood, in our setup, I think there should be a lot of quinolone and clarithromycin. This macrolide resistance must be very common. So and also when using the second line therapies like levoflox based regimes, that would also cause many problems. It is, as we know, it is a second line anti-TB drug, levo. So in our setups like endemic setups for TB, use of high loads of levo would be a problem in the future for selecting multi-drug resistant pathogens, and problem would be in second line therapy for TB. So those are the things that I wanted to emphasize. Other thing is, can't we use serology for, response to treatment, to assess the response to treatment? They are not.
It is not recommended. Actually, they recommend only for epidemiological studies.
Yeah.
Because what they say is, although we can measure IgM, they say that there's no value identifying acute infection from the previous.
Yeah, if there's a response, if we can have the titer, IgG titer, that would be useful. I don't know whether we are having the titer quantitative ELISA assay at the MRI. So if we have the titer, it should come down like in 3 to 6 months. Yeah, after 6 months we can say it has come down. It is eradicated. Like, yeah. Thank you.
Yeah. Yeah. So we know that aspirin, NSAIDs, and H. pylori are independent risk factors for peptic ulcer disease, and obviously they have additive effect. So if we are planning to start NSAIDs long term, the current the American College of Gastroenterology guidelines recommend to test for H. pylori. And if the patient is already on a low dose aspirin, they don't suggest. But again, if you are going to start aspirin in a patient, then they again advise to evaluate for H. pylori. But they don't describe what type of NSAIDs, whether it is etarocoxib or the diclofenac, they don't, or celecoxib. So they general, yes. Even the gastritis is much low with the use of etarocoxib. Yeah, I agree. But the recommendation is, if you are going to start NSAID, they recommend to evaluate for H. pylori. So this has been US guidelines. Their prevalence rate is less compared to our country. So even they recommend it. So, but again, it comes whether our patients can afford the stool antigen. So 2,000 plus, obviously, that is the practical scenario we have to face. No. No, adult ITP as a baseline, all we should do the H. pylori. So if it is positive, we should eradicate. Yeah, of course. Even simply with H. pylori eradication, about 43% platelet count improved more than 100,000. Complete remission. Okay. As a good question, so I discuss only about positive associations. So the H. pylori, sorry, the hiatus hernia is a congenital condition of. So actually, I will rephrase your question as gastroesophageal reflux disease and H. pylori. So it is interesting. It seems to have a negative association. So in the patients with H. pylori infection, they have less gastroesophageal reflux disease and its consequences such as Barrett's esophagus and esophageal adenocarcinoma. But imagine someone is having GORD and reflux esophagitis, and we do biopsy and we find H. pylori, but it is not a contraindication to treat H. pylori. But there's a negative association. So if someone is having H. pylori infection, they are less likely to have GORD and its complications. So if someone is having a hiatus hernia, obviously they are more prone to develop a reflux disease because of the loss of the sphincter function. So there were several associations affecting all the they were postulating basically every system in the body, but only up to now the adult ITP and the anemia, iron deficiency with or without anemia is the only two proven condition with a strong association, and also vitamin B12 deficiency. Right? But not the other conditions. They are actually other conditions is not proven. The Alzheimer's, HSP, strokes. Maybe you are. I'm not aware about that condition, but okay. Mm-hmm. Mm-hmm. Okay. As I mentioned, there were some speculation, but up to now, those three conditions are the more that they have found a strong association. Others are not that strongly associated. Yeah. That's the thing. Closer to us. Yeah. Actually, HNE is adequate. The only thing is there's some inter-observer error, I think. That's why they go for immunohistochemic chemistry. Otherwise, HNE is adequate. The thing is that we should, even for histology, some guidelines ask to stop PPI and antibiotics. That's the thing. So any more questions? So then I would like to thank all of you, and especially Dr. Chamika for coming here and sharing her important and interesting thoughts with us. And also I would like to thank our sponsors today, Sidus Cadilla, and thank you very much.
Good afternoon, everybody. Okay, that's the end of today's lecture. Thank you very much, Dr. Eranga, consultant gastroenterologist. Very informative lecture and lot of research-based evidence and updates on H. pylori.